Good afternoon, and today we have a pleasure of interviewing Dr. Tal Dagan. Dr. Tal Dagan, he's ENT, ear, nose, and throat, and plastic surgeon who practices in Manhattan and New Jersey. In Manhattan, he practiced he performed the surgery in Manhattan eye, ear, and throat hospital, and in New Jersey in Hudson Regional Hospital, as well as he maintained the practice. And today we're going to talk about all sleep procedures as well as cool reconstructive surgeries Dr. Dagan successfully performed. He performed hundreds of procedures every year, and some of them include very cool cosmetic procedures such as hand rejuvenations, and my favorite one, stiletto lifts, what the females can comfortably feel on the heels. But today we're going to focus on ENT procedures. And if you know someone who have a bad night's sleep or sleep next to the snoring partner, please click the like and share button. This way you can give your friends and family very helpful hints and ideas about the good night's sleep, as well as you can promote our idea of making this world a better place, because well-rested person is definitely a happy person. So today we're ready to learn from Dr. Dagan. Good afternoon, Dr. Dagan.
Hi, good afternoon.
We are very honored to have you on our channel. And my first question would be about Inspire procedure. I know you're one of the pioneers who performed that procedure in Manhattan and now in New Jersey without mask and without oral appliance. With just click of the button, you can the patient can have a good night's sleep. So please tell us about your experience with Inspire procedures. And my audience, after wearing the CPAP machine and, sometimes not so successfully oral appliance, that would be kind of next step. What was your experience with that?
Sure. So, first of all, the Inspire technology is a takeoff, kind of borrows the concept from cardiology, in the treatment of heart rhythm abnormalities, where they put in a device called a pacemaker, and what the pacemaker is responsible for is to detect heart rhythm abnormalities, and whenever there is one, to kind of create an electrical signal that alters or changes that heart rhythm back to normal. And from that, we can detect other things as well and use electrical stimulation for other purposes. The Inspire device was developed in order to also implant in the chest, just like a pacemaker is implanted, a pacemaker-like device, but what it measures, rather than measuring the heart's rhythm, it actually measures the changes in the movements of our chest, and then it can basically detect how we're breathing. And one of the things that are cardinal about diagnosing sleep apnea meaning no breath, as in we're not getting a breath. And obstructive sleep apnea is a condition in which we have one of two episodes occurring, either apneas, where we literally are not breathing for a certain amount of seconds to half a minute, usually in the average, and hypopneas, which are very shallow breaths that are akin to not breathing in the sense that they're not really ventilating enough oxygen to the brain and to the cardiovascular system to really provide enough oxygen for us to breathe. So we count both of those episodes, and that's how we determine whether a patient has or doesn't have sleep apnea. Now, the way that we diagnose it is kind of similar to the Inspire device. We also put special sensors on the chest cavity, and we're looking at the chest expansion to see, are the lungs filling up with air, or are they not, or are they only very partially filling up with air, which would constitute those hypopneas. And what the Inspire device is able to do is, when it does detect those episodes where our chest is not moving appropriately and we're not really taking a full breath, it will send a signal to a nerve that moves the tongue. Now, one of the things about sleep apnea is that because during sleep, for one of a few reasons that we'll discuss in a minute, we're not breathing, when the oxygen levels drop, they send signals. We have signals that are sent to the brain that say, "Hey, wake up." Not necessarily wake up as in completely out of sleep, but certainly wake up out of those deeper phases of sleep that are so important for us to rest. Rest is not just this virtual concept. Rest is our body is very similar to a cell phone. In the sense that, you charge your cell phone, you're supposed to charge it all the way. You're not supposed to charge it midway, and you're certainly not supposed to do that too many times because it degrades the chemistry of the battery. And our cells are based, or the battery is really based on cell concepts because our cells are very, very similar. You need to charge them. You need to keep things not just charged, but also get rid of all the breakdown products that occur from cellular activity during the course of the night. And we're dependent on that process in order for our body to function normally. If we don't do that, there are a lot of changes that can occur. And one of the there are many consequences to sleep apnea for patients who do suffer from them, because they ultimately will develop hypertension and heart disease, especially diseases of the muscle of the heart. They'll develop a multiple of symptoms that occur in the central nervous system, everything from daytime fatigue and drowsiness, but problems with focus, which can lead to attention deficit disorder. And a lot of people who are on medications, Adderall and so on for ADD, ultimately find out that they could have not taken those medications at all and just treated the underlying condition, sleep apnea. Depression, sexual libido, energy levels, ability to focus on tasks at work or in school, all those things are dependent on normal brain function, and all those are disrupted by sleep apnea. And then there are 14 identifiable eye diseases. The leading cause of blindness in the United States is macular degeneration, wet macular degeneration. And that is today very closely attributable to sleep apnea. So we know that there are a lot of things that it can cause, and so we want to reverse those. We want to reverse it, though, not in a way that doesn't allow us to charge and wakes us up, but just wakes up the appropriate muscle so that our brain function still is at a relative low and continues to rest, continues to kind of keep things down. Because our brain is kind of like if you go into a big theater and there's lots and lots of lights in different sections. You don't want to turn panels of lights, so to speak. You don't want to turn lots of different muscles back into activity during the course of sleep. You just want to turn certain muscles on, and that's what the Inspire does. It only turns the muscle function on, and therefore keeps you asleep, keeps the rest function and the recharge function continuing through the course of the night.
I absolutely love how you explain with the cell battery. That was great. And with the theater and the light, it was so visual and it's so great. And I learned so much from that explanation, even though I've been doing treatment for obstructive sleep apnea for 12 years. This fascinates me how you explain it. You really explain it great. And I have to admit about 14 eye disease. It's not so common for us to learn what, 14 eye disease contribute to obstructive sleep apnea. But last week I got a patient who actually losing the vision. She has a moderate sleep apnea and the vision just declining and declining and declining. Everything else was checked except sleep apnea. She cannot use the CPAP machine. So she might be a good candidate for this Inspire procedure. Now I have a particular question about Inspire. When patients use Inspire stimulation, does the mouth stay open or closed during the night? This is like a part of the question. And my second part of the question, a lot of people, they concerned about Inspire. They concerned about this additional, thing in the body. Is that severity of apnea correlate with the amount of stimulation they're going to get? Or you did not find it, or you find other anatomical features what imply on high level of, stimulation for Inspire? So it's like a two question in one.
Sure. So going back to what you were saying about your patient with the eye issue, One of the things that we call people who are diagnosed with blood pressure issues, high blood pressure or hypertension, and they don't have, there's not a cause for it. We used to call it idiopathic, and now we call it essential hypertension. We kind of make fun of the word idiopathic. We call the doctor an idiot because he doesn't know what's going on, and the patient apathetic. But in all seriousness, essential hypertension, which wasn't attributable to other causes and people kind of going on various medications. Now, cardiologists are starting to realize more and more the importance of sleep apnea as an underlying cause because we can actually get them off the medication. But as far as the Inspire and its effect on and relationship to apneas and so on, so the reason why we use or we tailor the Inspire device to patients, first of all, is because they failed conservative management. Usually, when we treat sleep apnea, we want to be conservative. We tailor one of two main treatments. The mainstream treatment is CPAP. Continuous positive airway pressure device. And basically what that is it kind of uses the same platform without having to implant anything, of course, the same platform of having electrodes on the chest. They measure the chest movements, and whenever they find those evidence of apnea or hypopnea occurring, instead of allowing that episode to persist, within a fraction of a second, the machine gives a burst of air under pressure, so it actually overcomes whatever obstruction is going on in the airway. And we'll talk about that in a second because it's related to your question. But it kind of gives a burst of air, and it overcomes apnea, hypopnea. It doesn't matter. It kind of it'll go forcefully past the tongue and give that breath that the patient was about to miss. So that's what the CPAP device is, and but the problem with CPAP is the compliance is not very high. 50% of people who use CPAP say, "I don't want to have anything on my face. I don't feel comfortable." Some people feel claustrophobic. Some people just don't feel comfortable with the touch. Some people awaken just from the mechanical aspect or the sound or noise. There are a lot of different sensitivities, and so although it's a very effective method when it works, people who use it and are able to use it love it. I mean, the sleep apnea is resolved. They don't get tired, and they function wonderfully. But for those people who don't, the alternative that has a slightly less chance of success or efficacy of treatment, but still very high, is an oral appliance. And what we do with an oral appliance is we make dental impressions. The dentist or the practitioner who makes these oral appliances will make a dental impression for the top teeth and the bottom teeth. And there are a variety of different devices out there for the treatment of sleep apnea. But the idea is that it takes the lower jaw and shifts it forward. The jaw and the tongue are interconnected. The tongue muscles are connected to the lower jaw. And so pulling the lower jaw forward, what we call in emergency medicine jaw thrust, opens up the airway, and then they can breathe normally and well through their throat, through their mouth. So oral appliance is definitely the top second choice for treatment of sleep apnea. But what happens for patients who either don't get benefit from it or say, listen, I don't want to have anything in my mouth. This is terrible. There are other ways that are conservative still to treat. There is a whole following behind myofunctional therapy, which is a variety of different exercises that exercise the face, the tongue, and so on. And it varies from tongue touches, where you push the tip of your tongue against your hard palate, the roof of your mouth, or tongue presses, or teeth touches, or trying to raise the roof of your mouth. What we call uvula raises, or even trying to blow up a balloon so that you kind of increase the strength of the muscles that control the airway, sucking yogurt or through a straw, or blowing a party horn. There's a lot of different things that people do in order to try to exercise. And there's definitely proof that that type of therapy can be effective for the treatment of sleep apnea. It usually in the current literature, we know that it can decrease the the severity of sleep apnea by up to 50% in adults and 62% in children. So it's not, it's definitely something to consider in the armamentarium of conservative management of sleep apnea. But then what do we do about those patients who are still in that 50% and they haven't responded? They didn't do well with CPAP, they didn't do well with the oral appliance, and they didn't do well with exercises. And then, of course, there are other conservative means like, sleeping on your side and having different body positioning pillows. I mean, there's all different type of things that people try to, from the grandmother method of sewing a tennis ball on your back so you don't end up sleeping on your back, because that's the worst type of position, as opposed to sleeping prone or on your chest or on your side. Past those things, it really comes down to an evaluation, investigation of what really is going on. The airway is very complicated, and that really gets back to your question of where is this coming from? People are sleeping with open mouth. Why are they sleeping with an open mouth? Are they sleeping with an open mouth because that's the way that they can get better air through their mouth? Or are they doing it because their nose is obstructed and that's the way that they get air in the first place? So it doesn't have to be that sleeping with open mouth is a habitual kind of thing that arises from something. So people do that, and people sometimes do that even after we've gone through their airway and corrected everything. It becomes just a habitual thing, and so it doesn't always have a relationship to any kind of obstruction. Sometimes just because, well, I don't know, I sleep with an open mouth. It's just the way I've done it for the last 30 years. So sleeping with an open mouth is a habitual thing, but it stems from something, or at least it started from something. The airway is very complicated because it starts from the nose, but it also starts from the mouth simultaneously, right? We can close our mouth and breathe through our nose, but we can't really do that when we're exercising. We have a really big hunger for oxygen. So that's when we open our mouth, because it's a very, very big opening. The reason why we have a nose is just because it's an air conditioner. It heats and humidifies the air that we breathe through through, and so it really conditions the air so that when it hits the lungs, it's not too dry, it's not too hot, it's not too cold. But the mouth is a very large capacity area that has a lot more room for flow when we need a lot of flow. When we're exercising, we'll start breathing in through our nose and out through our mouth, but we'll switch over to our mouth when we really have that oxygen hunger. So in the nose, we have a variety of different things that can affect the airway, from a septal deviation to the turbinates, which are these shelf-like structures around the side length of the nose that help to control that humidity and the temperature. And then there are things that can grow in the nose, polyps and tumors and adenoids in the back of the nose. But when we go into our mouth, the next floor down, there are all these other factors that can affect the airway. Everything from how our jaws are related to one another. Like if some people are born with a lower jaw that comes a little bit behind the upper jaw, kind of a backbite of the lower jaw, and that kind of brings all the structures backward. Now, our airway being round, when you bring something backward, you kind of close off the airway and you make it narrower and narrower. So the position of the lower jaw, the size of the tongue, where the tongue sits, where the base of the tongue, where the tongue kind of stems from, where that sits and its relationship to the back wall of the throat, all those things can help to determine how well we're going to be breathing. Because at night, we need to relax. We need to relax all of our muscles. And in all of us, the tongue will go backward. Some people think, oh my goodness, I'll swallow my tongue. You can't really swallow your tongue because it's tethered in place, but it does sink backward a little bit in all of us. But in anyone who's not suffering from sleep apnea, that relaxation is overcome by the force of our breath, the natural force of our restful breath during sleep. It's when we're unable to do so that we get those events. So based on an evaluation of that entire column of air through the nose and through the mouth and through the throat, because they're deeper down. There are other issues that can cause an obstruction. We come up with some kind of a treatment plan after we have exhausted the conservative measures, of course, of what can we do in order to improve the situation of things getting blocked. Does the tongue need to be advanced forward? Does the lower jaw need to be advanced forward? Do the components of the throat need to be jutted forward? Is there an obstruction? Are the tonsils very, very large so that even when the patient tries to breathe through the mouth with a relaxation and big tonsils that obstruct the throat, maybe that's the reason why the sleep apnea occurs. So a very didactic evaluation is one, it starts with the patient being awake, but sometimes we actually have to look at the patient when they're asleep in order to make sure that our assumptions of what is causing the airway obstruction are correct. So we actually do something called sleep endoscopy, where the patient goes to sleep. We put a special camera right down their nose into their throat to see where the collapse occurs. Where can we help the most? Because in the best hands, and the reason why we don't start with surgery only has 70% efficacy for the treatment of sleep apnea. We have to keep that in mind. The Inspire kind of comes in as an adjunct because it's in a way less invasive because we're not causing so much harm to the airway in trying to rearrange it. And it just tries to tackle the reason why we don't have sleep apnea when we're awake, which is the tongue being pulled forward.
But my question, going back to my question, people with Inspire, they have to keep the mouth. It doesn't matter how they keep the mouth. The mouth can be closed if they're using Inspire.
Yes, it can be closed or open. The position of the mouth is not as important. Again, habitually, some people will sleep with their mouth open, but with the Inspire, what the Inspire does, it doesn't affect so much the opening or closing of the jaws of the mouth, because those are different muscles. Those are chewy muscles. Mm-hmm. But the tongue muscle, which is the main culprit when we have, even in the face of all these different airway compromises that can occur, the tongue muscle moving forward can help to clear the airway. So open, closed mouth with the Inspire device is going to cause the tongue to move forward and open the airway. That's what it's designed to do.
No, that's very interesting. I want to ask you, we have a very limited amount of time and you give so much knowledge. I really appreciate it so much. I learned so much from that explanation of sleep apnea and Inspire. My question would be towards the young population. I get that question a lot from the parents who come in the practice and they had, the kids are not sleeping well. And you mentioned about ADHD, sometimes it's on a radar, and they got ENT evaluation, and ENT recommend tonsils and adenoids removal. And, I know you do a lot of procedures like that. Please share with us, if somebody not follow ENT direction, is tonsils, or is it absolutely necessary to have them removed? Or can be other remedies can be done. And still, like in the dental world, we talk about maybe if we expand the jaw, the tonsils would not be so huge. What's your opinion from the practical standpoint?
Okay. So first of all, remember that I started when we started talking about sleep apnea, one of the things I said is the first option is not going to be surgery. We're going to offer them conservative management. There's an exception to, one of the things we say in medicine is never say never and never say always. And I just kind of violated that rule by just saying never and say never. But the exception to the rule of don't offer surgery is when tonsils are an obstruction. When there's a very, very obvious obstruction of the airway, it's not because of the position of the tonsils, it's because of their size. When their size is so large that it is an obvious obstruction, it's the first thing we want to do. We're not going to offer them anything else. We're not going to offer conservative management or therapy, because if we do that, there is a 90% plus chance of the sleep apnea going away. When whenever we make decisions in medicine and dentistry, in any of the medical fields, we always want to weigh the benefit versus risk. the benefit versus risk for taking out the tonsils is so high as far as the benefit to the patient versus the very minimal risk to the patient, that it is completely warranted as a first step when it's determined to be obstructive. And it really, you need to be careful also when you're assessing. When I say take the tonsils out, it's because they are very clearly an obstruction, not they're a little enlarged. That's not a reason to take out tonsils. But when they seem to be an obvious source, or when we're looking through with a camera, or taking, sometimes we can also diagnose it with an X-ray and see that the adenoids are so enlarged that they're actually obstructing the movement of air. There's that should be the first step in treatment, and it really is an exception to everything else. No, we're not going to do much more invasive procedures to try to advance the jaw or expand the jaw and so on, when there's something that has a relatively short recovery time. There are ways in which we can mitigate and minimize the postoperative pain after tonsillectomy. I know that a lot of people are saying, oh my God, tonsillectomy, that was the worst experience of my life. There are ways to mitigate, and there are things that we do in order to reduce the chance that becomes a traumatic experience for patients.
No, this is a great answer, and I think it's going to be really reassuring. And I have my last question to you. I'm trying, reason for this, whole event and for this channel is to kind of create a close ties between the medical and dental community. And I'm not talking only about dentists. I'm talking about myofunctional therapists and hygienists and, people in our field who are so passionate about the sleep, and they really they see the airway. Not that many specialists actually see the airway, but we see it every day.
Yes.
And can you give us a word of wisdom how we can work closely with the ENT specialty for benefits of our patients, and specifically in the sense of myofunctional therapy? Because I know a lot of these procedures, what you do, I'm talking about, you do wonderful septum deviation surgery and turbinate reduction, which I want to talk and bring that knowledge to my listeners. You're such a great, professor. You explain things so well. We want to talk about that on our next interview. But this being said, all these sleep procedures you do, patients still have old way of doing things, old way of breathing through the mouth. How we can work, we do myofunctional therapy in the practice, and a lot of my colleagues do the same. How we can work closer with the ENT to create that bond and do successful service for the patient and for the doctors to make success of the procedures higher.
Well, fortunately, first, the septum, the nasal airway, is not something that the dentist needs to evaluate at all in the context of sleep apnea. As a matter of fact, patients who are diagnosed with sleep apnea, the only reason why I'll correct their nasal airway is because they're having difficulty breathing through the nose, not because they have sleep apnea. I don't make any false promises about their sleep apnea getting better. I tell them, if it does, it's a bonus, but that's not the expectation. So fixing the nasal airway is not necessarily the treatment for sleep apnea at all. And we don't design it as such. We certainly don't present it as such. So it actually makes it easier because the gatekeeper of the mouth is no one other than the dentist. The dentist sees all the mouths, young and old, and has the first peek into where sleep apnea really mostly occurs, which is the relationship of the upper and the lower jaw, the tongue, the teeth, the back of the throat. I mean, you're looking in the back of the throat. So any dentist should be aware of this. Any dentist should be aware of several things. The first one is if a patient seems to be overweight or obese, they are at a very, very, very high risk. There's a direct relationship to sleep apnea. So if you have any patient who is in the overweight range, it should be the first thing you should be asking is, do they have sleep apnea? You can ask very simple questions to kind of raise the suspicion level or lower it. And it really has to do with the fact that they go to sleep, they wake up in the morning, they don't feel refreshed, or they get daytime fatigue or drowsiness. They have vivid dreams. They shift their legs a lot during the course of the night. They have high blood pressure in addition to in their medical history. Those are the kind of things that should prompt you to then look in their mouth and see if there are any obvious things, just like we discussed. Do they have big kissing tonsils? Because that's something that if you talk to your local ENT and let them know, hey, take out the tonsils because I think that that's going to make them feel a lot better. There's going to be a pretty positive response to that. But it doesn't have to be surgical at all. You actually happen to be, as a dentist, as the gatekeeper and the person who is the most specialized and understands so much about dentition, are able to make all these different appliances. Just kind of learning how to, these are not run-of-the-mill kind of things that require a little bit more time investment, but learning how to make those oral appliances for sleep apnea, it's not that much more complicated than making them for TMJ. So it's certainly something that most dentists, I don't see why a dentist shouldn't get into it. Because it's something you can offer your patients. I think that every dentist should be in contact with a local ENT in their area, because evaluating for sleep apnea is something that obviously an ENT can very easily do, and then work closely with a dentist to coordinate treatment. I think I'm a big believer in collaboration across specialties. I believe in working with dentists. I believe in working with oral surgeons and maxillofacial surgeons. I believe in working together with pulmonologists and allergists, and so there are a lot of different relationships that we have in the ear, nose, and throat realm, and also with other ENTs who specialize in other things that I may not be my forte. So I truly believe the question should be really a statement, not should and what should dentists do. I think that ENT and dentists are a very important complement to one another. They both look at, very frequently in the same spaces, but each one has their strengths that the other one may not have at all.
Oh, thank you very much. It's been totally pleasure to spend this 30 minutes with you and learn so much. We're looking forward to talk about cosmetic procedures and snoring, let's call it snoring surgeries, the things that can improve the breathing. And I absolutely admire how easy you explain, and you make me excited to work in a close collaboration with your practice. Thank you very much, Dr. Dagan.
My pleasure, of course.